From your first period to your last, your menstrual cycle is a complex relationship between hormones from the brain and hormones from the ovaries. Menarche to menopause, tonight on Call with the Prairie Doc. Hello, I'm Dr. Debra Johnston, tonight's Prairie Doc. This season, we continue to bring our viewers trusted health information from doctors and health professionals within your own communities. Thank you for joining us again. Tonight, we are discussing women's health and hormones. And joining us in the studio in Brookings are Dr. Amy Kelley from Sanford Obstetrics and Gynecology Clinic and Dr. Dominique Boadwine from Avera Medical Group Family Health Center, Dawley Farm. Welcome, ladies. I'm so excited that you're joining us. Dr. Boadwine, I'm going to start with you. Tell us about your primary specialty and a little bit about yourself.
I do general OBGYN at Avera, and I have been there for 2 years now. I am married to my husband, Dan, and we have 3 young kids. You're a busy lady. We are busy. We just got a puppy. Oh, why not?
Apparently you weren't busy enough.
We were used to the chaos of residency, and life is now a little bit more stable, and Dan was like, why did we do this? Why did we go backwards?
Backwards, yeah. And well, because every kid needs a dog.
Yes.
Yeah.
Puppies.
Puppies are fabulous.
Exactly.
Yes,
yeah.
Exactly. Dr. Kelley, you're an OBGYN as well, but you have a little different emphasis than Dr. Boadwine. So tell us about that.
Yeah, so I specifically work a lot with pediatric and adolescent gynecology and have some extra training in that. And so probably about 1/3 of my practice is pediatric and adolescent gynecology. And then probably about another 1/3 is obstetrics, and the last 1/3 is just general gynecology. I grew up in Brandon, went lots of other places, came back to South Dakota, and have 3 children and 2 dogs.
So you're saying we need a second?
Well, your one dog is gonna get lonely, and then you're gonna get a second.
Buddy.
That's what what happened to us.
So all these nurturing people here, puppies, children.
Yeah.
Yes,
yeah.
Exactly. So we've really got you covered. We've got the whole range of women's health experience from pediatrics, adolescents, childbearing years, off into those postmenopausal years. So give us a call. Before we start our conversation, we invite you, our audience, to submit your questions about your periods or any other women's health issue. We look forward to answering your questions. Viewers can contact us in 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We'll work to answer as many of your questions as possible given the time available. And sometimes we receive more questions than we can cover, and we apologize if we don't get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of the program. Your question will remain anonymous, but please provide contact information when you submit your question. And we've already gotten some questions from our viewers, so that's a really good sign. And fortunately, it's not about training dogs, because I would really not be able to answer any of those. Maybe you ladies would be in better shape.
Maybe a little bit. Not much.
I'd be better at menopause.
Okay.
Same.
Well, that's fortunate because those are some of the questions we've gotten already.
Excellent.
We actually have 2 questions from email that are really very much overlapping. One person asking about vaginal atrophy and how to live with it, and another person asking about treatment options for atrophic vaginitis and bioidentical options. Can this condition cause increased urination and other damage to gynecologic structures? So 2 questions that dovetail very nicely. So, Dr. Boadwine, let's start with what do you tell your patients about atrophic vaginitis? First off, what is it?
So, as you transition to menopause, your ovaries are no longer releasing estrogen, and the vaginal tissue is estrogenized during your years of menstruation. So that provides the elasticity and the lubrication. When estrogen is gone, then you can have pain with intercourse and dryness, and that's called vaginal atrophy. We meet with our patients in the exam room and we take their history to see if they would be candidates for a topical estrogen cream, which would be the most beneficial option. Certainly patients with a personal history of breast cancer that are hormone sensitive, that would not be an option.
At least not initially.
Yes,
Yeah.
yes.
So
Primary option.
yeah,
And
I think that sometimes people, sorry to interrupt you, but I think sometimes people worry so much about vaginal estrogen. They've heard all these bad things about taking hormones
Estrogen
and
therapy.
bad things about estrogen. And vaginal estrogen is actually a very different beast because it really is made to only affect the vagina. And so some people who may not be candidates for oral estrogen actually can use vaginal estrogen. There are actually some very good options out there for people.
So, of course, as a family physician, primary care doctor, vaginal estrogen is something that I talk about with people a lot.
Yeah.
But it's not the only option, and you don't always have to go straight to medical prescription type options. So, what are some non-prescription things that women who have some vaginal atrophy might be able to do?
Yeah, and I think the one other thing I'd add to vaginal, talking about what it is that you actually don't have to just be menopausal to have a little bit of this. One of the main people I give vaginal estrogen to is actually people who are postpartum. Because the other things that really decrease the estrogen in your body is breastfeeding. And so women who are breastfeeding, especially women with multiple children who are making a lot of breast milk, can end up with a lot of atrophy too, and then they have pain with intercourse. And it can be a big problem for breastfeeding women. Certainly over-the-counter things that you can try is, of course, you can use lubricant if your main complaint is during intercourse and dryness during intercourse. And a lot of times that's enough for people. The other thing that you can try is there's a couple of different vaginal moisturizers. I like Reverie. Most of the ones that you would want to try would be ones that have hydrouronic acid in them because it helps keep the pH in a good level for the vagina. Do you have some specific things you like to use over the counter?
This is good tip. I'm fresh, so this
Yeah, that's so nice to have someone that's like right out of training, and then I have been, I've been out of training for 15 years.
It's nice to feel like the old wise woman sometimes, isn't
Oh,
it?
not old.
Thank you. Thank you.
Yeah, I'm like, I'm not too old, but yes.
But you're the wise woman. So,
There you go.
Yes.
But really, I think lots of people are so worried about using hormones in the vagina, and actually, it can be safe. There are some things that act like vaginal estrogen, but are technically estrogen as well, and those are prescriptions. But there's a oral medication called Osphena that works. It works kind of like an estrogen, but it only works like estrogen on the bone and on the vagina. So that can be a nice option for people. And the other one is Inarosa, which is a different hormone that can also work a little bit like estrogen on the vagina. So there are some different options out there.
And I've heard some of the kind of more advanced treatments about like laser treatment and those kinds of things. So
we have more recent literature that has said that the laser treatments don't necessarily make a great impact clinically. So the Mona Lisa is the most common laser treatment, and they found that scores are similar in patients who have Mona Lisa and who are blinded without it.
Yeah.
Unfortunately, because that was a cool treatment.
Yeah, it was cool. It was a nice idea, and I think that that's the thing that makes it hard in medicine, I think, for patients is things change over time.
We learn more.
As we learn more. And so, that can be really frustrating and confusing, I think, as a patient. Because
and as a doctor.
Yeah, absolutely.
Yeah.
Absolutely. But the Mona Lisa was something I think we had a lot of studies about, specifically for breast cancer survivors, because often the treatments that that we use for breast cancer really lower estrogen levels, and so vaginal atrophy and issues with that can be so hard for breast cancer survivors.
So one of the callers had asked about other implications. We've talked mostly about pain with intercourse, vaginal dryness. What other symptoms or consequences might a woman experience from vaginal atrophy?
They could have a little bit of postmenopausal bleeding. They could have some infections, erosions, in certain circumstances.
Yeah, with certain things in the vagina, like pests, certain other things that are in there can cause more erosions. I find that some people, if it's really very significant, especially like with breast cancer survivors, I find some people do have some urinary symptoms from it, because the urinary tract, the urethra, is really right above the vagina, and that tissue is estrogen sensitive as well. And so I do know that there are urologists and also a lot of gynecologists who help treat some urinary issues, and it's not always the primary treatment for some of that, but it can help.
Can be part of it.
Yeah, it can be
Both
part of it.
The incontinence and sometimes the recurrent urinary tract infections are.
Yeah, both of those, and also sometimes just like irritative symptoms, like people who feel like they have to go to the bathroom a lot. Sometimes that can be helpful as well.
So good.
That triggered pelvic floor physical therapy. So in addition to the pharmaceutical things, I think our physical therapists are such a good modality of care that if they have some stenosis from the atrophy where that vaginal tract is narrowing, physical therapy would be a phenomenal option for patients.
Yeah,
I think
absolutely.
Physical therapy, pelvic floor physical therapy is something that's really exploded in the last 10 years, and rightly so. I mean, it really makes a big difference for.
It is life-changing for some people. It really can be.
It really is. Men and women.
Yeah, absolutely. Yeah. And, I think America is a little behind in that. If you look at Europe, almost everyone who has a baby in Europe has part of their postpartum care is pelvic floor physical therapy. Yeah.
Wonderful. Well, let's look. We've got, oh my goodness, a lot more questions here. All right. One person, this kind of relates to some of what we have talked about. What is hormone therapy, and is it safe?
That is like a huge question.
It is, isn't it?
That's like a whole hour episode easily.
Let's open the can.
I am old enough that when I came out of training, I can remember having conversations, just trying my hardest to get 80-year-old women to start taking hormone replacement, because we really believed that this was revolutionary and so important, and things have changed a little bit after the Women's Health Study.
And when I was in medical school, the Women's Health Study came out, and so there was this big swing, like all hormones are bad, nothing. And I think that we've kind of come back to, I don't think any of those approaches were right. Not everyone should be on hormone replacement, but also like
not
for some
no
people,
one.
Correct. For some people, it can be
life-changing.
It can be a really good treatment for certain things. So I think that we've kind of come a little bit more back to the middle, where I often tell people like hormones aren't good or bad, and it depends on what hormones we're talking about, because there's thousands of hormones in your body, right? So if we're just talking about reproductive hormones, they're not good or bad, but it's all about like the amount, the timing. It's very complicated, and so a lot of it depends on like the personal and family history of that person, what their risks are for the future. what their past history has shown or their personal history of risk, as well as like what are their goals, like what are we trying to do for them, and what are their symptoms. So it's a very complicated question that's hard. We try to answer individually, so it can be kind of hard to talk about like it in broad strokes in some ways. Yeah.
Sometimes I have people come to me and ask about, first off, I want to test my hormones.
Oh.
Exactly, which sounds like it should be really easy. Dominique, tell our viewers, why is that a very difficult thing to do?
So throughout your whole life as a woman, your hormones could be any number at any given time, and they're fluctuant by the hour, by the day, and they don't have a lot of clinical relevance. So when we have patients who are maybe in that perimenopausal state and we want to prove, hey, your FSH is really high and your estrogen is really low, that can tell us like, oh, this supports a menopausal state or a state of menarche, but in between, or reproduction. It's helpful for our reproductive endocrinologists.
Yeah, for people trying to get pregnant.
But at any other time, there's not a lot of benefit from that information because it's not going to change your management in what the numbers show.
Yeah. Because you don't know where are you in that ever-changing cycle. So having one number doesn't
tell you very
really
much.
tell you very much.
And the other thing is there's a lot of things that women take that affect those labs. You know, I often have women come to me and they're like, I got my hormones tested and my estrogen and progesterone is really low, something's wrong with me. And we chat and they're on the birth control pill. Well, guess what? That's normal when you're on the pill because that's how your body responds, is by keeping those levels low. And it's just a function of being on the birth control pill. And then here they spent hundreds of dollars and it didn't tell them anything. And so I think, that's the real thing. In medicine, I have a very strict belief and tell medical students this all the time. We shouldn't check things if it's not going to change what we're going to do, or it's not going to add information that we need to know.
That we need. Puberty is the time when physical and emotional development changes kids into young adults. Prairie Doc reporter Sam Schauer spoke with pediatrician Dr. Daniel Boadwine about how parents should have open conversations about this transition and what physical signs they should be looking for.
Dr. Daniel Boadwine is a doctor at Avera Health in Sioux Falls who helps adolescents with signs of puberty. He says for girls, 8 to 13 years old is when puberty starts, but that doesn't mean the first period will occur immediately.
Typically, it's not the first thing that comes during puberty. Usually that's breast development, whether it's breast buds or just the tissue surrounding the nipple. That's usually what will start developing first. And then most of the time, within a couple to about 2.5 years, most young women will start to have menarche or that first menstrual cycle.
Dr. Boadwine says that on average, 12 to 12.5 is when girls will have their first period. For both boys and girls, puberty can be a rough time in their lives with their emotions, bodies, and friendships.
But your body is going through this immense change where you have these really big influx of hormones, and it can be, really difficult because you're trying to grow, you're gaining height, you're having, your voice might be changing, you're ending up with armpit hair or pubic hair, and just your body might be changing, and it might even be changing at a different time than some of your friends.
This can lead to some adolescents feeling confused, especially when it comes to sports.
They'll say, well, so-and-so has started puberty and it looks like they've started developing and I'm 12 and I haven't yet, and I feel different and I feel like I'm behind. And so talking about that with kids, I think, can be really imperative to their not only letting them know this can be physiologically normal, but it can be really helpful for their mental health too.
That is why Dr. Boadwine likes to bring up puberty to adolescent patients and their families around 7 to 8 years old.
I want them to know so they can ask me about it. If it's too early in a young girl who's maybe 7 and starts to have breast development, well, then we can talk about that and we can decide if there's any further evaluation or referrals we need to do to make sure nothing is happening too early.
He says some girls might not even experience puberty until they are 11 or 12, but he likes to bring it up to families in case some girls start earlier.
There can be many reasons why that might be the case, and you may have already had other signs of puberty beginning, whether that was at 11 or 12 or even 13, but if you've gotten to 15 and have not had a menstrual cycle yet, that's a reasonable conversation to have.
Such an important topic, and actually we had someone come in on email and say that their child is 10 and what should they be looking for to gauge when their child is going to start puberty. So what a wonderful little bit of extra information for them.
Yeah.
So good.
Absolutely.
Good.
Yeah, that's great.
Yeah. So what do you recommend, because I know this is an area of special interest to you, so what do you recommend that your parents talk to their children about when they're starting to talk about puberty?
So you stop me if I go too long, because this is my jam and this is what I love. So I think there's so many different things to talk about when it comes to puberty. Like there's puberty itself, which for young women, sometimes women, especially women of color, will have signs of puberty at 7 or 8, and that's not actually abnormal. And so, really, you have to be talking about this a lot younger than you think sometimes. And so I think, 7, 8, 9 is a really good age to start preparing girls for what puberty is, what it means, what to expect. Because if you don't know anything, you suddenly get your period, like that could be really scary for a young woman. And those women who are the first people through puberty, it's a little tougher to be the first girls in your class to go through that. So having your mom kind of helping you walk you through that can be super helpful. But outside of puberty, there's also lots of other things to talk about. Those teenage years are so tough. I have a couple of them in my house. And you also you need to start talking about consent. Bodily autonomy, about, God forbid, sex. And I say that jokingly, but it's true. Children do need to know some basic things about sex around 8, 9, 10. And they don't have to know the whole shebang.
And you want to hear it from your parents before you hear it from your friend at school.
Mm-hmm. Yeah, exactly, because your friend at school probably doesn't even know what they're talking about, let's be honest. I use the term 8 is great, 9 is fine, 10 is too late. Now, it's never too late to talk to your kids about this stuff, so that's kind of a misnomer. But by 10, you're probably going to have to not only talk to your kids about it, but also talk to all the things they've heard that are wrong, because they'll have heard a bunch of stuff already. And it's much easier to talk to an 8-year-old. They don't even know they're supposed to be embarrassed by this stuff. So it's much easier to kind of get into that when they're younger than when they're a little bit older, actually. So
important information, and important to make sure to keep those lines of communication open.
Absolutely, because
kids.
It's not one talk. I mean, if you are, it's talks over time. You're not going to tell an 8 or 9-year-old about STDs necessarily. It's a conversation that you have in bits and pieces as your kids grow up and as they need more information.
Yeah, you don't have to answer questions they're not asking.
Correct, yeah.
You just need to make sure that you're giving them the opportunity and giving them some information to chew over and think about so that they can think of their questions.
Yeah.
Exactly.
Absolutely.
So here is another question from email. Is it normal for my child to have irregular cycles? They have just started their period this last year. Dominique.
So I always like to talk about this with my teenage patients. Your body is really cool as a woman. You have a gland in your brain that communicates with your ovaries, that communicates with your uterus, and they all have to work in sync to have a menstrual period. So any stressors can throw off that signaling process at the very beginning of it all. It can be an immature axis. So those messaging signals aren't necessarily in sync every single month, just like her mom's might be. But as the first couple of years progress, they'll become more normal. Certainly it is the best time to talk to a provider about the menstrual cycle, because we know that the menstrual cycle can be a good vital sign and tell us a lot about a patient's health.
So obviously women that have just started having their periods, things can be very irregular and chaotic for them. What's normal for older women? What's normal for your 25-year-old woman who comes in? If she says, you know, I don't get a period every 28 days, does that worry you?
So it depends on how often she is getting a period. So, and is she on something that's stopping her period? Because there are definitely methods of contraception that do change the frequency of periods. So it depends on the woman. But in general, we consider normal periods to be every 21 days to 35 days. So that's the first day of your menstrual cycle to the first day of the next one. And so it can vary a little bit. A lot of women do have cycles that are very consistent, like 27, 28, 29 days. But it's not necessarily abnormal for them to vary just a little bit more, particularly if you're not on something hormonal for contraception. And you know, we would usually, I tell people if they're more than 7 days, if they're heavy, you're changing a tampon more than every hour or two consistently for more than a couple of days, then maybe it's time to come talk to us. If you are having pain that is making it unable for you to go about your daily life, and is not really helped with ibuprofen, then it might be time to come talk to us as well. But yeah, not every woman has periods every month, because sometimes we deliberately make that not happen. So, you know, and that's okay. I think that, you know, I often tell young women just getting their period, if they have very irregular cycles, like that can be normal, but it also can be very frustrating for a young woman, someone who's a gymnast training or who's in cross country. Like, you don't want to get your period in the middle of a cross country meet.
Or on a trip to band camp or whatever
absolutely,
else.
Absolutely.
Yeah.
And so, I mean, I think that, yes, periods are natural and they're fine to have, but like we have the ability to help people's lives be a little bit better if their periods are bothersome to them or causing trouble. Yeah.
So assuming you're using these methods, is it safe to not have a period? Dominique?
Yes. So a lot of patients ask me, is this going to impact my fertility in the future?
Absolutely.
And what I'd like to point out is sometimes when we start a form, say a combined oral contraceptive pill for patients who have something called polycystic ovarian syndrome, which means that their ovaries aren't releasing an egg and their brain is not telling their ovaries to release the egg and their uterus to have a period. We give them their period with that birth control pill, that we were disguising a condition that might have caused infertility in the future. So oral contraceptive pills or any form of contraception or hormonal therapy that might suppress a period certainly does not impact fertility.
Yeah,
but
absolutely.
The caveat is that maybe we were treating a condition that might have influenced fertility in the future.
Absolutely. Absolutely. Yeah.
And
that's
and
a super common problem. A lot of patients worry about
that. And I like to tell people, you know, if you're on birth control and now you're 35 wanting to get pregnant,
it's going to be harder
it's
than when
harder
you're 20.
than when you're 20, than when you're 25. So delaying fertility impacts your fertility.
Yes.
But the birth control pill
You are
that
on-
you use to
yeah.
delay is not
the
what
factor.
what
Yeah.
was the factor.
Yeah, it's actually really interesting. I really enjoy medical history, and one of the things that I found out in reading is that the only reason that there are placebo pills in birth control pills, so that's why you get pills, or that's why you get periods with pills, is there's a week where, or sometimes less, but some pills that do not have hormones in them, and then you have a withdrawal bleed. And the only reason those were put in is marketing. So in the 50s, a marketing team thought that women would find birth control pills more acceptable and natural if we had our periods. there's not actually a medical reason for it.
Which is why we can do extended cycling.
Correct. Yeah.
Yes.
Yeah.
But not with every pill.
No,
Yes.
yeah, there's some tricks to that. That's true. There are some tricks to that.
I should add to that our gynecologists treat like an endometrial condition that would be a precancer with those forms. So it is actually sometimes beneficial to suppress the bleeding that you're having.
Yeah, some hormones treat cancer.
Yeah.
Yeah. Yeah. So, we have a viewer says, what are some of the more uncommon symptoms of perimenopause, and when should you go to your doctor? Dominique.
Uncommon symptoms. So let's start with the common symptoms, and maybe we can brainstorm this together. So vasomotor symptoms, so hot flushes, weight gain, vaginal dryness, like we discussed before, mood swings, abnormal uterine bleeding. So it's the same thing as I spoke of when you start your period, when you start menstruating, as your ovaries end their life, your periods become irregular again. So those would be the common things. Can you think of uncommon?
Perimenopause is so individual. I think that's what makes it really hard, is everyone has kind of individual symptoms. What I have found over the years is that many times some of those symptoms are actually a consequence of something else. So for instance, a lot of people talk about not sleeping well. That would be another one that's common. And then we talk about, well, are you having hot flashes? And they're not sleeping well because they're having hot flashes. So it's not necessarily that perimenopause is causing the sleeping problem always. Sometimes it's that it's causing a bunch of hot flashes and then you can't sleep and then you're crabby because you are not sleeping.
Because that's how we torture people, is by not letting them sleep.
Yes, absolutely. And so sometimes I think that, while yes, it could totally be that weight gain and your mood swings are from perimenopause, sometimes if we fix some of those other things, sometimes those get better too. A couple of things that I've had people come in with that are a little bit more unusual, and it's always a little hard to tell if it's from perimenopause or not, but actually I have a lot of people who come in with some joint pain. And obviously a lot of people get joint pain as we get older, just from arthritis and overuse, wear and tear. But sometimes it seems to be very specific places, or like not always related to activity. So, and some of those people have benefited from having like some hormone therapy. Their joints have felt better. So that's one that I don't see very often, but occasionally I do. Yeah.
And let's throw out some definitions here.
Yeah.
What is menopause and what is perimenopause? Dominique, what is perimenopause?
So menopause would be when you go 1 year or 12 calendar months without a menstrual period, without any form of suppression. And then perimenopause is the time before that where you might be experiencing some of these symptoms. Your menstrual period might be irregular, and that would be the perimenopausal period.
And how long does perimenopause usually last, Kelley?
That depends on your person.
The luck of the draw.
It's the luck of the draw.
Thank you, Grandma.
So I have people who slide into menopause and don't have a one hot flash, and their periods are right as rain, and one day they stop and they're done and they're fine. I have other people who start having hot flashes, some moodiness, difficulty sleeping, even 10 years before they go through menopause. So it varies a ton.
What is the average age of menopause in the U.S.?
52.
Okay. One of the biggest moments in life will be deciding you are ready to have a child. Prairie Doc reporter Sam Schauer takes us to Sioux Falls to talk with Dr. Keith Hansen about the importance of talking with your doctor prior to getting pregnant.
Dr. Keith Hansen is a doctor from Sanford Fertility and Reproductive Medicine, and he talks about the starting point for a couple thinking about getting pregnant. One of the first things Dr. Hansen likes to do is an optional screening to check their family and genetic history.
We just have to collect a specimen, either saliva or blood, send it in, and then they can test it and tell us if they carry cystic fibrosis, spinal muscular atrophy, or any of these other really serious genetic illnesses, and then we can talk to them about the illness, explain how we can help them, to avoid that illness.
After that, Dr. Hansen likes to help the couple enhance their health before getting pregnant, whether that be managing diabetes or changing medication to not harm the baby.
The better health that a person is in before they get pregnant, the less likely they are to have complications during their pregnancy. We also like to evaluate them to see if they have an underlying medical issue that needs to be, treated or optimized before they become pregnant.
Another thing Dr. Hansen likes to check with adults is checking with their recent immunizations and see if they're up to date.
Because it's really important for a woman and her husband too to be up to date on all their immunizations, because we've come a long way in medicine to be able to treat our patients with vaccinations that have reduced the risk of getting some serious illnesses during pregnancy, which can be devastating to the mother and devastating to the baby.
Once all that is checked out, the woman must stop whatever birth control they use, and Dr. Hansen says once periods return, couples should be ready to start trying for a pregnancy.
And as soon as you start having regular periods, as soon as you start ovulating, which usually is, regular periods are usually a sign of ovulation, then they could start trying to get pregnant.
Dr. Hansen says the prime time for trying to get pregnant is roughly 6 days, with the last day being ovulation.
The best time to get pregnant is within that 6-day window. The pregnancy rate really drops outside of that time period.
Dr. Hansen does bring up that as a woman ages, it will be harder for a couple to get pregnant.
As a woman grows older, her chances of getting pregnant reduce because of, the ovaries start to not work as well, and there's an increased risk of chromosomal anomalies, which increases the risk of miscarriages.
Pregnancy is such an important part of women's hormones, and getting pregnant is sometimes a bit of a challenge. So when do you like to see your patients who are in that contemplating pregnancy stage?
I really like to see people as soon as they're considering pregnancy. There are a lot, I think people worry about the medicines they're on. Most women are on several different prescription medications, and they want to know if it's okay to stay on those. Sometimes it's really important that they stay on them. And so I would much prefer to see people, in the 6 months to a year prior to them trying to get pregnant, because if they do need to change a medication for a very important medical issue like seizure disorders, sometimes you have to change your medication. And we want to do that and want them to have that under really good control before they get pregnant. So that's kind of when I like to see people.
Anything to add, Dominique?
I think I completely agree. Before even attempting pregnancy, it is good to see patients in the clinic to talk about their menstrual cycle, because infertility alone is a very lonely path, and to go 6 months to a year without conceiving and not understanding why or what's happening, I think having that conversation and knowing it is common, it is not normal, it is going to be okay. Call us, we are a resource.
Yeah,
and
absolutely.
I think that having that in front gives some hope.
Yeah, I usually tell people to come in to call us at 6 to 8 months if you're not pregnant. It is average though. I mean, average people, it takes 6 to 8 months to get pregnant, so that's very typical. But I often have people give us a call in that range if they're starting to get worried, because then we can get them in a couple months, and hopefully if they hit that year and they're still not pregnant, we have an appointment set for them and we have to talk about it.
And we may not want to wait that full time period. If I'm already 38, 39 years old.
Then I say 6 months.
Yeah.
Almost. Yeah.
So those are a lot of very individual things
absolutely.
that we want to consider about. Lots of good questions here. So here's a pregnancy-related question. My daughter was labeled a geriatric pregnancy. I hate that term. Oh my gosh, I hate that term.
Yes.
What is a geriatric pregnancy, or
Can we please call it advanced
Yeah,
maternal age?
yes, sounds a little less harsh.
A little less horrible.
Less harsh. So over the age of 35, there are pregnancy is the greatest risk to a woman's life, regardless of the age that you are at.
Pregnancy is a very dangerous
time.
situation.
Yeah. But we know that over the age of 35, the risk of gestational diabetes, the risk of hypertensive disease in pregnancy, the risk of aneuploidy or chromosomal abnormalities with babies increases significantly, exponentially compared to before. So it seems like an arbitrary number, but we have to have a cutoff at some point. So 35 is what it was.
Yes. And you're right, it's terrible to call it a geriatric. It's just because you're certainly not geriatric.
No.
But
You're
accomplished.
Yeah.
Yes, there you go. Thank you. You're seasoned. We're the,
Accomplished.
the
We're
wise,
seasoned.
seasoned wise women.
But it's important to know that there are some risks at that age. Even, they go up slowly at first and then more rapidly as you approach 40 and over. But it doesn't mean you can't have a healthy pregnancy. I think just being aware of that, seeing your doctor beforehand, talking about those risks is just super important to do. So you know what to expect and what you're getting into.
And we'll try to keep that geriatric word out of your chart.
Absolutely.
Certainly before you're 70. The closer I
geriatric.
the closer I get to geriatric, the older geriatric gets in my mind. So here's someone who says, I have had hot flashes, but I still have my period.
Yep.
How can you tell if you're perimenopausal?
Yeah, she probably is. I was just saying, join the club, me too. Although I don't have periods, I guess, because I have a Mirena, but which is
a
an
wonderful,
IUD.
yes, a
Yes.
wonderful treatment with that possible side effect of the no periods,
Yes,
which most
absolutely.
women love. And I tell my patients, most med students, that's what they use.
Actually, most female physicians use IUDs as well.
Yes.
That's the most common.
So it's okay not to have your period when you have your IUD.
Yeah.
So
Yeah, no, she probably is. And I would usually tell people get your thyroid checked because that can be another common cause for hot flashes. I usually look through people's med list because occasionally they're on a medication that can have that side effect. And then we talk about why are you on this medication, and usually I talk about is this something that it's more important to stay on and deal with the side effect? Is there another alternative? We talk about those kind of things. But if that's normal and they don't have any meds, welcome to perimenopause.
So we talked a little bit about this, can they do a blood test and find out if they're perimenopausal?
So we talked about before, the blood tests don't reflect what they're clinically feeling. So the estrogen can be stone cold normal, and they might be feeling terrible.
Yeah.
And from
Save
day
your
to
money.
day, it can go up and down a lot. I call it mayhem, actually. Like, that's the term I use, is menstrual mayhem when I talk to people about it, because it kind of feels like that to some people. But that doesn't mean you can't be treated for your hot flashes. Like, I have an estrogen patch on, and it is very helpful. So you don't have to be menopausal, meaning not had a period
done.
for a whole year to get treated for your hot flashes if they're bothersome.
That is a very important point. So, and oh my goodness, what are complications health-wise associated with menopause? Dominique.
So when the hormone therapy, we thought we should prescribe it to everybody. It was because we observed that women die later than men because of the hormones that their ovaries release, because they're cardioprotective. So we know that until women reach menopause, the rate of cardiac disease is much lower than men. And then once they reach menopause, that kind of really accelerates. So after menopause, cardiovascular disease is certainly something that a patient would really want to be aware of. Urinary issues, osteoporosis. So your bone density is kind of at its peak in your 30s, and then after that it plateaus and starts to go down. So I speak with all of my perimenopausal patients about the importance of fitness and building that muscle to combat all of it. You don't have to have an expensive gym membership. You don't have to have a lot of equipment. You don't have to run half marathons. A lot of tips that I give them is when you're going to the grocery store, park in the last parking spot in the parking lot. Take the stairs everywhere you go. If you can do planks, do planks. If you can lift some free weights, do that. But building that muscle and taking care of your cardiovascular health will just benefit you in the long run. I think we really neglect bone health, and we know that at a certain age, bone fracture is the major cause of death. So building those muscles and protecting hips and arms is important.
Yeah,
We are,
and it helps with menopause. Exercise is great.
Great. We are almost out of time. I think we have time for one more question, and I'm going to give this one to you, Kelley, because I think, what would you say to a young woman worried about her first pap smear?
Oh, I do a lot of first pap smears.
I love doing first pap smears.
I do too, actually. So first of all, I think it's really important for everyone out there to know you don't have to have a pap smear until you're 21. It didn't always used to be that way. The only exception to that is transplant patients who do need to start younger if they're sexually active. But there aren't too many transplant patients at that age. There's a few. And so typically what I tell people is it's going to be about 20% of how bad you think it is. It's always going to be much easier than you think it is. I do lots of first pap smears, and really, if someone uses tampons, they are going to do fine. They're going to do fine. And we'll walk you through it. Yeah. You will be in control. It's uncomfortable and it's weird. It's mostly just weird. Yeah. But I typically, I have the luxury.
Should be minimal pain.
Should be minimal pain. And if you do have pain, you need to tell us so that we can talk about, is there a problem? Do we need to help you with something?
And the winner of our prize, this has been such a great conversation, ladies. I'm sorry we're going to have to cut it off here. The winner of our prize tonight is Lisa from Rapid City. Thank you, Lisa, for asking a question during the first 20 minutes of the show. A gift will be sent to you, and we'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 21 seasons. Join us as we continue to provide health information based on science, built on trust. Follow us on Facebook, Instagram, and YouTube to access the entire Prairie Doc library today.
Aristotle is said to have referred to the female as a mutilated male, and this philosophy carried forward into much more modern times. In 1977, official FDA guidelines recommended that women of childbearing potential be excluded from early-stage clinical trials. Men, particularly white men, were considered the ideal model from which the success and side effects of any particular treatment could be judged. Somehow, women's menstrual cycles made them too difficult to study while simultaneously being irrelevant to the results. The thalidomide tragedy quite reasonably brought fetal well-being to the front of researchers' minds, but there was reluctance to wait for animal teratogenicity data before starting human trials. Companies often interpreted childbearing potential to mean childbearing age, and then extended that ban to all women in all stages of research. Studies carried out in the mid to latter part of this last century frequently enrolled thousands of participants, but no women at all. This was even true in purely observational studies where nothing was being trialed or tested. Then, in 1993, Congress passed a mandate that women be included in NIH-funded trials, and the FDA changed their guidelines. Now, They said that the population studied in trials should be representative of the people likely to be treated with an intervention if it were approved. This meant that most studies had to include people of different ages, races, and genders. Once scientists started looking, it became evident that the differences between us translated to differences in the way diseases develop, the way conditions present, and the way we respond to potential treatments. We may need different doses. We may experience different side effects. We may need different treatments altogether. This can be true for differences based on age, race, health status, and of course, sex. The landscape today is very different than it was in 1993, but we still have a long way to go. A recent review of studies involving cardiovascular disease, cancer, and mental health interventions found that just over 40% of study participants were women. Cardiovascular disease and cancer affect men and women almost equally. In mental health research, the situation is worse. Women make up approximately 60% of those affected, but still just over 40% of those enrolled in trials. Everyone deserves to know that the recommendations their doctor makes are backed by science that includes people like them. Many treatments work just as well in people of different races, ages, or genders, but many don't. And we won't know if we don't ask that question. Thank you to our guests, Dr. Amy Kelley and Dr. Dominique Boadwine, for volunteering their time to help us learn more about periods. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us live most Wednesday mornings at 9:30 on KBRK in Brookings. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
No, and it's just, it was...
mean good eye health, keeping you connected to your surroundings, the importance of eye health. Next time, On Call with the Prairie Doc.
My name is Jennifer May. I'm a rheumatologist in Rapid City, South Dakota. I got involved maybe around 2005. That's when I first started practicing in Rapid City, and my former partner introduced me to Rick and actually got me on the On Call show. I think we did a story on gout, and that was my first introduction to Rick and the Prairie Doc sort of concept. And it's a great resource for information. We have a lot of people that live in remote places. They maybe don't have a lot of good access, and we know that there's a lot of misinformation in terms of health information that you can get online, and having a reliable source for people to go to with people they recognize that they might know on the programming, I think is really important. Well, I think having anything that isn't tied to an agenda is really important, and so having access to information that you can refer your patient to, that you know they're not going to get fees or get their data sold, is really important. I think if people want high quality programming from local people, local experts that supports your community, supporting Prairie Doc is the way to go. For more information or to donate, please go to www.prairiedoc.org or mail your donation to Post Office Box 752, Brookings, South Dakota 57006. Thank you for your support.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings, Madison, Flandreau District Medical Society,
Pierre District Medical Society,
Sioux Falls District Medical Society,
Yankton District Medical Society,
Orthopedic Institute,
Lake Ponset Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communications.